University of Medicine and Science and completed her pediatric residency at Advocate Hope Children's Hospital. She further excuse me, with a fellowship in pediatric pulmonary medicine at the Medical College of Wisconsin. In addition to that clinical training, she holds a master's of business and administration and medical management from the University of Massachusetts in Amherst, and is a certified physician executive through the American Association of Physician Leadership. Her dual expertise in medicine and healthcare admin supports her work in leading multidisciplinary teams, implementing evidence-based practices, and improving patient outcomes across the pediatric continuum. All things that we want to do as good public health professionals. So without further ado, I will hand it off to you, Shimoni. Your turn.
Thank you. Thank you so much for that lovely introduction. I'm going to go ahead and share my slides real quick. All right. When I was first thinking about this topic, and I really thought this is more of a topic within a topic, right? We think about asthma as a big picture, but obesity, I think, is a central part of it. So I think I'm excited that I have a few minutes to share a little bit of information about this diagnosis and disease process, and the interaction between the two. So the first and foremost disturbing thing that I learned is that by 2020, 50% of the US population will be defined as obese, meaning a BMI over 30. I think we've kind of the last decade or so have known of this obesity epidemic as something that's coming, but I really think it's here, right? When you're facing half your population has a diagnosis, then it's almost kind of going from epidemic to pandemic in the sense that it's very prevalent. And I think addressing obesity-related disorders are essential, and asthma being one of them. So asthma itself is not a obesity-caused disorder, but more of a multifactorial disease that's determined by genes, that's determined by environment, that's determined by exposures, hereditary, overall westernization of our civilization, all of those things, right? Obesity is a risk factor that can cause asthma, like symptoms, asthma itself, all that is associated as a risk factor, but there is no causation. Having obesity does not result in having asthma. And I think that's important. As we go through this complex relationship, and I have a bunch of slides, you'll notice how they're intertwined. There's not a direct this does this, but there's so many other potentiators. So this is an important slide, I think, that we need to look at. And as you see, oh, I'm sorry, I don't know how that moved. As you see that obesity is on one end, asthma is on the other end, and they're related to each other, right? But despite being that direct relation, there's a lot of different factors. So you have metabolic factors, you have physiologic factors, environmental factors, what we ingest, or dietary factors. There's also within us, there's hormones, inflammatory markers, metabolism, and then there's different kinds of disorders that we ourselves may be experiencing that can also contribute to this correlational relationship, right? So I'm going to take this chart and kind of break it down, and we're going to talk about how one, if not all of them, truly affect your asthma. So this is a chart, and in my training, I used to have an attending who always said obesity is a chronic state of inflammation, and I completely understood, agree with both of those, but I needed to have a pictorial to explain how obesity is a chronic state of inflammation. So when you look at this, right, you see on here, you guys can all see my pointer, am I correct? You see that this is adipose tissue, right? And adipose tissue secretes a lot of these cytokines. And whether these cytokines act on your mitochondria and your neutrophils, your eosinophils, they at some point, those cytokines result in airway remodeling. And there are not just one or two pathways, but you can see there's a multitude of pathways that start with adipose tissue, which is fat tissue, and then pro-inflammatory markers are released at different levels. They're affected on different cell type, and as a result, we have different kind of airway modeling, malformation, all of that that continues to occur. I'm not going through each of these cytokine pathways, but I did a talk a while ago on biologics, and some of these cytokines are the same cytokines that we talked about in terms of targeting airway inflammation as well. So this is important, right? Because I just set up a slide with lots of pictures and ILs and different markers, and you can look at that and get really overwhelmed. But what I want you to take out of that is that obesity is a state of inflammation, and that does increase oxidative stress. And as you know, oxidative stress results to cell damage. There's also lower levels of eosinophilia that you may see in the blood and sputum compared to T2 high asthma that you think about. There can be lower levels of IgE FeNO because this may not necessarily be a high allergic inflammatory asthma rather than a non-allergic inflammatory asthma, which you can see in obese patients. There's elevated IL-5, IL-6, IL-13, cytokine, chemokine receptor activity. And then there's also different polymorphisms of lectin and adiponectin. These are cytokines that are released from the adipose tissue, and they're associated with obesity related phenotypes. And I'm going to spend some time at the end and talk about different phenotypes and types of patients that we would see. So physically, right? We talked a little bit at the cellular level, and now let's take a look back at a more bigger picture global level. So you have decreased chest wall compliance, right? When you have more fat tissue over on your neck, on your body, everything is kind of a little more restricted. And so you may not have great expansion of your chest wall. You may have poor compliance because you're not having great expansion. And this is all because you have increased adipose tissue. When you do PFTs in these humans, you may see that some of your parameters are decreased, total lung capacity, how much air you can really take in because you have so much pressure externally. You might not take that big deep breath in. You may just say, right? And so then your FEV, FVC, residual, everything can be affected. Also, obesity is associated with airway airway dysynapsis. And that is a mismatch between airway tree size and lung volumes. So airway caliber is always smaller and disproportionate to the lung volumes, right? In people that are obese, just because there's not enough growth, the volume is compressed, all of that is abnormal. And we've noticed and noted through studies that this puts you at a higher risk for asthma exacerbation. Also, there's an inverse relationship of estradiol and testosterone to asthma prevalence. This is really important. And when I was going through this, I kind of had to review this a few times in my head because some of the hormonal changes are kind of counterintuitive. So adipose tissue in postmenopausal women is the only source of estrogen. Obviously, in premenopausal women, we know that we have ovaries and other areas where the estrogen can be released, but adipose tissue is the only source. And that's why postmenopausal women are so deficient in their hormone. And now we're starting to see that labeling is coming off and saying, yes, hormone supplementation is okay. Estradiol obviously is increased in obese women that are postmenopausal because they have more adipose tissue, right? And so when you have increased estradiol, you may have decreased asthma prevalence. But when you have postmenopausal women that are obese and overall relative estradiol's decrease, you can have increased asthma prevalence. So keep that in mind. Premenopausal will also have decreased levels, right? Much less in non-obese compared to obese. And so that's another time that you may see that some of those um, uh, decreased estradiol may have higher prevalence as well. And then obese females that are post-pubertal and have a lot of adipose tissue, you can also see the incidence of asthma prevalence change. Having said that, lower testosterone in males also gives you a higher asthma prevalence. So there's many comorbidities, right? We've touched upon some results of it, but we all know sleep apnea is one of the comorbidities. You have a lot of neck fat mass, and so when you lie flat, that impinges on your airway as a little pressure system, and so you may experience obstructive sleep apnea. You can also experience acid reflux, a lot of fatty tissue, eating foods, spicy foods, oily foods, all of that gives you acid reflux and can even mimic asthma-like symptoms, if not contribute to them. Mood disorders, depression, anxiety, with the mood disorders, oftentimes you're not exercising, you're not getting yourself out there, and you're more likely to perpetuate that cycle of poor exercise, increased anxiety, increased depression, more weight gain, and then really decreased movement again. Metabolic diseases, so people that are pre-diabetic or diabetic, they have a wide variety of sodium glucose abnormalities that can also result. And then obviously we know heart disease, hypertension, dyslipidemia, all of that. They all contribute to some form of an inflammatory cascade that makes asthma worse as well. There's also miscellaneous other factors that I didn't want to, dwell too much, but I think you should know. There's an increased diversity of our microbiota that is associated with airway hyperresponsiveness, right? There's more pollution, there's more out there in the world. We've westernized, right? We have more processed foods, we have more made things rather than naturally grown things that we see over there, that we used to see 2 centuries ago. So all of that have changed our gut biome as well. And then pollution, we talked about environmental factors. So obese patients with asthma seem to have more harmful effects of airway pollution because airway pollution causes inflammation, obesity causes inflammation. Together, you have more compounded inflammation that results in all this. So this is a very loaded slide, but I think you need to look at it, right? It goes into various different things and how it affects you. So we talked about all the comorbidities, reflux, diabetes, cardiac disease, metabolic, sleep apnea, depression. You also tend to see changes in your pulmonary function. You see your inflammatory markers that are stated on the right side of the screen at the bottom are all increased, resulting in more cellular oxidative or more oxidative stress at a cellular level. And then you have more phenotypes, different types of phenotypes. You have the late onset asthma, the early onset asthma, the neutrophilic asthma, the mixed granulocytic phenotype asthma. And those are some of, in the biologic talk I had discussed a little earlier about all the different phenotypes of asthma. Eventually all contributing to this, your severity, your risk of exacerbation, your control, your response to treatment, and then eventually impacting your quality of life. So I do want to, because if you were not here for that other talk, I do want to discuss what is late onset asthma phenotype. So that's older women, they tend to have less allergic inflammation, which is Th2 inflammation, less atopy. They often obese, they have frequent other comorbid men in primary care. they may have ATP, they may have more eosinophilic Th2 inflammation. They can also have airway obstruction if they're young and obese, and their airway is. They often need treatment, frequent treatment with oral corticosteroids, and often have frequent hospitalizations due to exacerbations. Neutrophilic phenotype. Neutrophilic phenotype is more of that high inflammatory with neutrophils, right? So you're going to see this in severe asthma, people that are sick, older women, longer duration, takes them a long time to recover. Not as much ATP because it's granulocytic, so more neutrophilic rather than eosinophilic inflammation. And then you have constant remodeling going on of the airway, and then you start to see a steroid resistance, frequent exacerbations. So that's, to me, that's a very scary type, right? Because they're sick on multiple ends. And then a mixed granulocytic phenotype is one that has both neutrophilic and eosinophilic. So they're going to have ATP, but not as much as somebody who is high eosinophilic. They're going to have airway obstruction, frequent exacerbations, but they don't always just have, non allergic symptoms. They have a component of that. So you're really needing a lot more steroids for them as well. So interventions, right? We all need to work on dietary, behavioral, surgical, pharmacologic interventions against obesity associated asthma. I just spewed out 4 big categories: dietary, behavioral, surgical interventions, and then along with pharmacologic, obviously. Those are big categories. That's a lot of intervention on its own. So dietary, like I've mentioned multiple times, we're in ultra processed food mode right now. Everything is high sugar content, preservatives, not everything's plant-based. So we really have to teach our population, let's change our diet to high in fruits, vegetables, omega-3 fatty acids. We need to work on insulin resistance in these obese people. So with the GLP-1 agonists, metformin, all of those have really helped bring patients on our side to say, all right, well, I know you're working hard on eating healthy, eating right, and this may not be fast enough. Let me see if there's something easier. And then really exercise, right? We kind of take that as wayside. We're all busy human beings. We all are. But we need to get up. We need to exercise. We need to carve that into our culture to say, if we all exercise, we're all taking care of this, we're less likely to succumb to obesity, and hence it help decrease the incidence of asthma or prevalence of asthma. Non-surgical weight loss can improve airway inflammation and asthma control. So I don't think everybody has to feel like that's it. I'm either getting a gastric bypass or I have to be on an agonist. These are all different aids, but any weight loss of any form is going to help. Oh my gosh. I don't know why these 2 slides somehow got switched, but this is supposed to be my picture this in practice slide, okay? So you have a morbidly obese patient with frequent exacerbations, right? So you're treating them with medications, environmental factors we have to look at. Are there pets, are people smoking, or is there something going on? You need to look at diet, exercise, to make sure that they have carved out some of that time. And really socioeconomic factors, I think, are really important. We don't give this enough credit, but when people can't afford healthy foods, when people they don't have the ability to go buy things that are good for them, and then eat them and then consume them and then exercise appropriately in a safe environment, I think you're likely to see a lot of these. And then multifactorial care is essential, right? When you talk about a morbidly obese patient who is a severe asthmatic or even a moderate asthmatic, you can't just say, oh, I'm sorry, you can't just say, this is it, you're getting these meds, go take care of yourself. You really have to sit down and address all of these factors, which is what's contributing to them. These are my references. And then I am open to taking any questions that you guys have at this time.
Yeah, please go ahead and put any questions in the chat. I always have questions. The estradiol definitely tweaked my interest, and I probably will have to go back and look at the slides again. But if just maybe simplistically, are you saying the less estradiol a woman has, the more her asthma or she may get late onset asthma, or the asthma or it could be both, or the asthma she already has could be become worse, more severe.
It can be both. Yeah.
Oh, okay.
So
Okay.
estrogen is a protective in terms of asthma exacerbations, and so lead to have either
You're
severe asthma or frequent
exercising and eating
exacerbations.
right, you will have less adipose fat as well. So you will
Exactly.
have less as you get older. So women are kind of caught. If I'm hearing you correctly, this strange
Yeah,
hormonal somewhat maze.
exactly.
Okay.
But if you are a non-asthmatic and non-obese, then it's not a thing for you, right? So now if you're an asthmatic that's also non-obese, you may have to look at some hormone supplementation if that is helping.
Mm-hmm. For sure. For sure. Any other questions, anyone?
Yes.
Go ahead, Mark.
Hi. The situation I have, I'm connected with a doctor on the East Coast. She's a professor of medicine, and her focus is on gender difference. That many physicians, because a lot of research is only done in men, do not understand the differences between male and female. And it's important, especially with this regard of the estradiol, to understand the differences in how you approach the patient. You're not treating a symptom, you're not treating a disease, you're treating a human being. And you've got to look at what's in front of you and make sure that you understand the different components of the hormones and the physiology, gender wise, to make proper decisions.
Yeah, I think I think that's a given, right? Like if when you look at each patient, you have to look at different factors that are influencing each patient. And that's why I said multifactorial care is so essential in these people because uh, there's catamenial asthma too, like people that have significant fluctuations with their menstruation or women, and so they can have abnormalities. So I think you do need to look at those, and a lot because of that, during your menstrual cycle, estrogen decreases. Women can experience significant symptoms due to those uh, like the hormones plummeting.
Do we have any other questions? I don't see too much. If I've missed something in chat or quickly come off mute. If there's nothing else, Dr. Dharia, I think bottom line, we want people with asthma to exercise and be controlled in exercise. Um, that's something we want to have happen.
Yes,
Correct?
I think the bottom line is we have to treat obesity, the epidemic, the pandemic, both of it, and that will help decrease the comorbidities with asthma. And as a pediatric provider, I see this in kids that are 3, 4, 5 years old. And when their BMIs are already 30, 32, 35 as a 5-year-old, 6-year-old, it's very concerning into adulthood and all like into puberty, adulthood, and post-pubertal time, how much that's going to affect their asthma.
Sure. And if you don't somewhat change those behaviors or just become more in tune with those behaviors as a child, preteen, as you
Right.
grow, it's get harder as an adult.
Yes,
Derek, go
ma'am.
ahead.
Thank you so much,
See your
Dr. Ari,
hand
for
up.
this important topic. Right now, I'm working in a military community and also in a community that's sort of a semi-retiree community and dealing with definitely with the female population. And one of their concerns is, and I'm glad you bring this inflammatory component with the asthmatics. Are you seeing or have you heard of anything with the GLP-1s for some patients that are asthmatic? because it is this chronic inflammatory condition. Do you see those medications working in conjunction with the standard medications that we're using to help control our asthmatics as they're working to lose weight?
Yeah, so Derek, I'm a pediatric provider. Majority of my patients are not on GL1, but I have to preface that with saying when I looked at all the literature, because they're losing weight, there's decreased inflammation. It is definitely helping. And plenty of studies will tell you that using the GLP-1, helping decrease the inflammation, will help with their asthma exacerbations.
Thank you so much.
Mm-hmm.
Good to know. I mean, because that's becoming so, I hate to use the word popular, but
yeah,
it's being used. Okay, well, if there are no more hands, I don't see anything in the chat. I'm gonna, heart everyone. Thank you for taking this time to be with us this lunchtime. This is been told this is lunch and learns, and so our next ones will be starting our winter lunch and learns, and they will start in February. Geometry, and it's another one that we just talked about that, but there's another. I'm sure it'll be on our website soon. What we'll be talking about in the winter, but your presence matters. Whether you're here to learn, connect, share experience, we are definitely grateful for all that you guys are doing, all the work that you do to keep us healthy, to keep the community going, and being good professional, good public, as I say, good public health professionals. So thank you for coming. And
Felicia,
I will emphasize again to go ahead.
Derek has his hand.
Oh, Derek has another question. I'll just say slip in while Derek is talking and take a picture and do the evaluation. Go ahead,
Okay,
Derek.
thank you so much. I'm sorry. I'm trying to drive and listen and engage as much as possible. Dr. Dari, so
No,
w-
but go ahead.
with our pediatric population, and once again, thank you so much. How do for the primary care provider like myself, are you encouraging, not encouraging, but what can we do better to help identify those patients that are in that persistent category before they get to that severe, trying to keep them in that moderate and mild category as much as possible, try to control some of their identified allergens. What are you suggesting, recommending
Yeah.
for us in primary care?
Yeah, so I really start out y- when they're young, even the mild ones. I talk about eating healthy, exercising 30 minutes. And for kids, I just say go out and play. Like, don't forget that's what kids are meant to do, right? Go out and shoot the ball. Or and then as they get into tweens and preteens and they're not leaving their house, and I talk about how, use your textbooks that you may not be studying for and just lift it up 5-10 times a day. Or 5-10 times at a time, use canned goods, and just kind of do more of your quote unquote exercising that way. Zumba on YouTube, hip hop on YouTube, whatever it is, you have to get yourself going. Once they're a little into the teen world, and we talk about muscle building and muscle mass and all of those, so I talk about that. I also really hone in on how much juice, soda, chips, cookies that they consume, right? Like on a regular basis, I talk about 1 or 2 dietary items that I educate on. So I usually always start out with juices, because that's an easy fix, and telling them to do carbonated water, or telling them to do soaked fruit and making it their own little mini juice, things like that. Those are easy interventions. I talk about cutting out uh, how many times they bring chips or cookies into the house, right? So it's hard to say don't ever eat cookies, especially with the holidays coming up, but to say, hey, maybe instead of bringing a bag of chips into your house once a week, maybe bring it once every other week, and then once a month, and things like that. So you have to focus on that when they're mild. And then I never actually tell my really tiny kids that they need to lose weight. I tell them they have growth vertically that is still pending. So when they still have room, all they have to do is eat healthy and convert that fat to muscle. And it's not going to happen right away. But as they get older, it's more likely to have, they're more likely to build that muscle mass if they're eating healthy and become slimmer. So I tend to talk to most of the kids with BMIs of 30 and higher about this kind of stuff. They're obese, that they need to know that. I have had patients that are 400, 500 pounds that are the age of 12, 13, 14, 15. And we do talk about, especially the older ones, we do talk about gastric bypass and some of these other alternative therapies that I do need them to pursue, because a 15-year-old that's weighing 500 pounds is probably not going to drop, let's say in the next 3 years. That is a hard, long feat, not just for them, their family, everybody, diet change, culture change. So at that time, they may need additional help. But when they're 4, 5, 6, we really talk about lifestyle changes still.
Gotcha. I love those strategies, and you've given some simple things that they can incorporate. Of course, I'm 58, and so going outside, playing, uh, uh, jumping rope, playing in the dirt, drinking out the water fountain, that was a lot easier to do now. But staying inside can be a little bit challenging. But using those simple strategies, I like that. So thank you.
Oh, thank you.
Yeah, there's a question from Dr. Alvarez.
Yeah, I do. I keep it very simple. And I do tell them that obesity overall results in swelling of your body, but it also results in swelling of all the cells and pathways and things like that, right? Parents don't understand what a chronic state of inflammation is. They don't. So I talk about how obesity affects their breathing when they sleep. I actually really correlate it to each of those comorbidities. I talk about how obesity affects heart disease, how it affects sugars, all of that. And when you start talking about each of those things, I think the wheels slowly start turning on them to say, okay, it's what do you mean by inflammation? Well, all these organ systems are being affected, rather than just affecting a lot of these different organ systems, and really are not just affecting. I kind of keep it very simple and just talk about how obesity affects asthma in different modalities. I know that's not a straightforward answer, but I think when you have really little kids, or even tweens, it's very hard to kind of talk to them at the level that we're discussing right now.
What a great, I don't see everybody to view, so I don't see anybody else. One, twice, 3 times. Okay. Thank you for joining us. Go ahead and take a picture of the code on the screen. We will be sending out our winter. If you have any questions, even after this, I'm sure Dr. Dharia, and we can get you her email or get the questions to her. Okay. So, all right, I'll go out, get some air, work out. I already worked out, so you guys go work out and watch what you have for lunch today. Okay.
Thank you, everybody.
Thanks.
Thank you, everyone.
Thank you.